Kia ora, I'm Dr Helen Fulcher and I'm speaking with Dr Alistair Dunn, a general practitioner from Northland and addiction medicine specialist. Welcome, Alistair.
Hi.
Alistair, Tramadol is a drug that is prescribed in primary care and is often seen by both clinicians and patients as a safer option pain relief drug compared to other well-known opioids. But addiction specialists around the country paint a much less rosy picture about Tramadol. Can you tell us a little bit about this?
Well, the Tramadol is a synthetic opioid and it's quite a strong painkiller, much like codeine, and has the same effects as codeine. Common ones such as dry mouth or constipation, perhaps less constipation than codeine. The other thing that it has in common with other opiates is it has an addictive potential, and from my work in addiction medicine, that's the thing that concerns me. Tramadol has complex mechanisms of action because it doesn't just act on the opiate mu receptor, it works on noradrenaline and serotonin receptors. So the other effects it can have that we need to be mindful of is that it lowers seizure threshold, and importantly, especially if it's combined with an SSRI, it can prompt serotonin syndrome. Another side effect that elderly patients can experience with Tramadol is hallucinations, which can be quite impressive. The risks associated with Tramadol have now been recognised by the Ministry of Health, and they've just recently reclassified Tramadol as a controlled drug, Class C controlled drug, the same as codeine, which reflects that there are some potential risks or harm associated with it.
You've mentioned that the first prescription is really important in this process. What are your tips for managing this in a way that reduces risk?
Well, I think if you've gone beyond the first few weeks and it looks like this is turning into a long-term problem, having really tight dispensing arrangements is a really good safety feature. And I think even weekly dispensing is a good idea, because if the prescription's picked up on the same day every week, it'll become readily apparent to the chemist or the GP that the person's picking up early. In other words, using more than they meant to and running out. A second thing is to have a review date regularly so that you can review the progress of the treatment. Now, with other medications like antidepressants, when you reach a certain dose, if you're not getting good effect, then you stop the medication and you try something else. But we seem reluctant to do that with opiates. We'll keep prescribing them even though the person reports they're still getting pain. A second thing is to remember about a dose, maximum dose. And I think if you agree from the outset that you're only going to go to 200 milligrams or at the most 400 milligrams of Tramadol, then it's clear to the patient that that's the limit. Importantly though, I think at the beginning of the prescribing, if you set the scene by saying you expect this to be a short-term prescription, that the inflammation and damage that's going on will heal, then that helps curb patients' expectations that this is going to be a long-term prescription. So when we're talking to patients about is this medication going to help your pain, traditionally we've often used pain scales. So a patient says they're getting a pain of 8 out of 10 and we're going to see if they can get to 3.5 out of 10. So I don't really use the pain scales. I try and look at functional goals. So you need to explore with the patient, what are they trying to get out of their daily lives, or what would they like to do? What are the things that their pain is hampering them from doing? I mean, if they're housebound, maybe the goal is to get to the letterbox to get the mail, or walk down to the dairy, or maybe take the kids for a walk, something like that. And that's going to be a motivational goal for that patient. So when you review the efficacy, when you review how the medication's working, you can just ask them, well, how are you getting on with getting the kids down to the beach or something? And that's the way to review whether the medications work.
So Tramadol is clearly a drug we need to be careful about prescribing. What are your take-home messages for health professionals about Tramadol?
As well as the important pharmacological issues about lowering seizure threshold and serotonin syndrome, for me the message I'd like to get across is that it's an opiate, and like all opiates it has an addictive potential. These medications can be easy to start, but they can be hard to stop.
Great, thank you, Alistair.